So thank you very much for this kind invitation to speak here. It's a pleasure for me to tell you a little bit more about the Competence Network for Integrative Medicine, who we are, what we do, what type of collaboration it is, and the possible added value it may have as a model for the European level. And it's my big pleasure to give this talk sitting next to Mrs. Mielich in the ministry in Stuttgart, and speaking from here to you. So this is the outline of what I want to tell you briefly. And we just start. That was in 2017, so 3 years ago, when our Competence Network was founded with the patronage of State Secretary Bärbel Mielich, who has been a close follower to what we do. She always, when we have symposia, she comes and speaks, and we can always address her with questions. And so it's a huge thank to you, Mrs. Mielich, that you are really somebody helping this initiative. And you can see the 10 hospitals who were the founding hospitals and the primary care network and research institutes. These are the logos of the hospitals who collaborated in the very beginning. And when you look at this photo, you can not only see a nice remembrance of our founding ceremony in the middle, but you can see that these are very different hospitals, small hospitals, big university clinics. And this diversity is very important for us in the KIM, in the Competence Network for Integrative Medicine, because what we want to do is to develop treatment recommendations to work on best practices in integrative medicine that would fit to be spread in different types of hospitals, not only in Baden-Württemberg, but abroad as well. So the KIM now in 2020, this is who we are. There are 15 hospitals and outpatient centers, outpatient networks and academic research centers. And if you look at the trust structure of hospitals, you can see that there is a strong academic input within these hospitals. We have 3 university hospitals under our collaborators, 8 teaching hospitals, 3 general hospitals. And within these hospitals, there are 2 comprehensive cancer centers, 2 out of 13 in Germany. This is the highest level of cancer care provided in specialized centers. And we have 9 hospitals with different clinical cancer centers. And Professor Kramer mentioned the collaboration with the 4 universities in the AZKIM. And we are very happy that there is public funding for some of the specific projects within the KIM by the Gesundheitsstandort Baden-Württemberg, an initiative of the government of Baden-Württemberg, which can be translated as healthcare location Baden-Württemberg, most important fields for the future. Our members have a lot of scientific collaboration worldwide. I do not go into detail. And if we look at the structure, first of all, I have to say it's a very, very democratic structure. We have the KIM members, the plenary assembly, where everything is decided what we do. They choose the steering group and they choose the spokesperson. One is me and the other one is my colleague Marcella Winkler from the Robert Bosch Krankenhaus in Stuttgart. And then we work in working groups. The working groups are really looking at the integrative therapies and the symptoms of patients which can be addressed by that. And we have doctors, the medical experts, oncology group, and the nursing group, and both work on the identification of best practices and they develop recommendations. And they are supported, so to say, from the other side by a methodology team. So a team that works on tools for documentation, that works on tools for evaluation and collaborates with the AZKIM. And of course, what is very, very important for us, because we are a network of hospitals you can reach within 1 to 2 hours drive, is that we identify an expert pool. So if you have questions for acupuncture or to naturopathy or for other nursing therapies, for example, there's always somebody who can be asked for training, for counseling in another hospital, or for job shadowing, so for hospitations, because we want to learn from each other, not only in theory, but in practice. If we look at the emerging paradigm of integrative medicine, I just want to mention 2 trajectories. Emerging paradigm means that this is going to develop all over the world, in the United States, in South America, in China, and India, and Europe. And we are in the middle of the process. So what will sort out, let's say, in 10 years is not yet there, but we can see what are the trajectories. And a first trajectory, sorry, I have to go back. A first trajectory is that we come from an old culture of parallel systems. So in the older times, in the last century, complementary medicine meant this is somehow coexisting but not collaborating. And today it's about combination, and it's not just the patient preferences, but we are today working of meaningful contributions and integrative therapy concepts. So the major role today is more the clinical centers in the research than the primary care. Another important trajectory is that today, and that's why I'm speaking really for all our colleagues in the KIM network, we work on integration on the second level. So we collect best practices from different traditional and complementary medical systems according to specific diseases and specific symptoms. So it's not that one whole system is important, but that we try to focus on diseases and their symptoms and then collect the best practices from the different fields of complementary medicine. And then we want to learn how can it be integrated into oncology units. And of course, this type of integration of best practices may lead to something like a common trunk of integrative medicine. Lots of textbooks, which are now there in the field of integrative medicine, deal exactly with this question. So if you look at that in integrative oncology, rheumatology, cardiology, you find there always the best practices and the contributions from different traditions in complementary medicine. And there are global societies, expert societies like this one, Society for Integrative Oncology, where international standards and international recommendations and guidelines are going to be developed. So the strategic question for cancer therapy in the next decade is, how do we integrate the integrative therapies, and how can we create sustainable models of institutional implementation on a larger scale, not just for a minority of patients? In our network, you can see here which types of complementary therapies are there. It's acupuncture and Chinese medicine, anthroposophic medicine, naturopathy, quite strong, the nursing therapies, art and music therapies, mind-body therapies, mindfulness, nutrition, and patient counseling. And when we started the network, we worked on a common definition, not a definition on a theoretical level, but on an implementation level. And so this is it. It's that we want to see integrative medicine integrate into specialized hospital units as a meaningful combination of conventional, good oncology care and complementary methods, following patient symptoms, patient needs in a patient-centered approach in interdisciplinary teams. And of course, in every hospital, this should be led by a medical doctor with a double competence, so trained in conventional medicine and oncology, and at least one complementary tradition. And of course, for us, it's absolutely clear that we work on a scientific basis, that we want to see an integrative evidence-based medicine on the basis of all three pillars of integrative medicine. Professor Kramer showed you that we want to have this middle circle integrating literature and best research evidences, clinical expertise, where we see that clinicians have to be asked and nurses have to be asked about their experiences and the patient values. And it's extremely important to follow the founder of evidence-based medicine, that evidence-based practice or evidence-based medicine is the middle of these three circles. So how do we do that? When it is about identification of best practices in integrative oncology, we always start to identify the most important symptoms of cancer patients. So we do not start with different cancer entities, breast cancer here, and lung cancer there and gastrointestinal cancer there, we start with the symptoms of cancer patients. For example, cancer fatigue, or loss of appetite and weight loss, or sickness and vomiting. So we categorize these symptoms, then we collect from all our hospitals what is in use and what do the experts think, what are the most valuable therapies with the highest impact on outcomes, looking for life quality of the patients. And so we describe these therapies. Is it medicines? Is it nursing manual therapies? Is it acupuncture? Is it mind-body therapies? We list it under every specific symptom, and then we scale this, we rate this. So we first ask the experts. These are hospital units with a long-standing tradition, sometimes over decades. We ask them, please tell us how effective is it with the patients on a scoring scale between 1 and 5. Then we ask them what kind of training is needed for doctors and nurses. How much time does it need? And again, we score that. And then we ask how much time is needed, because hospitals, there is dense work. We don't have much time. We want to see, can it be integrated really? So again, a scoring scale 1 to 5, and feasibility. So what else is needed? And of course, for every method, for every medicine, for every treatment approach, we look at the external evidence, the scientific publications. Of course, we integrate that. And we look at side effects and possible interactions, because what we do should be sure for the cancer patients. And this is, sorry for that, it's in German. You can see that there's a clear definition what these 5 categories mean. So it's very transparent, it's very precise. And you can see, for example, this is nausea and vomiting, so sickness and vomiting as the main symptoms for cancer patients. You can see, for example, aromatherapy, progressive muscular Entspannung, acupressure, and C-band therapies. You can see all these categories, what notes, what score gradings was given by the expert in the different working groups. And when we started in 2017, we said, this is so important, because what we want to develop is best practices by means of a help when you start with implementation in KIM hospitals, but in U hospitals, that you get a clear understanding what does a method really mean in practice, that you do not only look at the studies, but that you look of what training is needed, how much time is needed, do you need special rooms or other things. So that's why we feel what we do in this competence network of healthcare providers is in the middle, if you want, of the circle, and we want to make understandable what would it mean to implement some of these best practices, and there we want to help new hospitals to do this. And of course, looking for the future, Abraham Lincoln said the right thing. We want to predict our future by working for a good future. And I thank you very much, finally, with a slide in German. Thank you very much for your kind attendance. And I give back to Tito von Schönanger, the moderator. Thank you very much.